is that the amputation rate, especially for diabetic patients experiencing particular arterial disease, has rose during the last year dramatically. This is a self-explanatory graphic taken from the Centers for Disease Control and Prevention in the United States, and this is a graphic from 1980 to 2005. You can see here very nicely. In the same time, very sadly, that the amputation rate has grown. Moreover, only 25% of the patients which are getting a major amputation will be able to amputate again. And this is from the social, from the financial point of view of the health insurance system all over the world, a very big and tremendous problem. So, of course, the concept of this is not new. The concept of therapeutic neoangiogenesis has been fostered in order to try to offer another possibility for these patients when they are past the open vascular surgery and the interventional angiology phase, so they are awaiting major limb amputation. And of course, there are many concepts, molecular concepts and cellular-based concepts to reduce this type of process. I'm going to talk about the methylcoliforming cells because these were the ones that we picked here at the Pittsburgh Research Center to try to develop into a vaccine. So looking in the literature, we saw that in the inferior limb, for example, this is a study made on 38 patients which received this type of therapy, and this is a graphic showing the ankle-brachial index, and this is before treatment, and this is after treatment. So there's a steady improvement with medial ankle-brachial plexus index of 0.14, and this was promising. And this is another much newer study. This is the LX-MyelCell-T. This is a product, actually a cell-based product, which has been tested to see whether it can prevent major limb amputation in patients experiencing stage 4 Fontaine peripheral arterial disease. So you can see here, very interestingly, that while the controls have event means major amputation, while the controls had over 80% of events during the study, the group of patients which were treated with this vaccine were only to 45%. Of course, about stem cells and methylcoliforming cells, there are a lot of questions to be answered yet, and some of those questions we were prepared to answer through the study. And so first we aim to generate the cells, to characterize the cells, and then to investigate their neoangiogenic potential. And first we had to develop the Hindley ischemic models. So what we did, we took rats and sequentially ligated their popliteal and femoral arteries. And you can see here very nicely that as compared to a control, which is non-ischemic, the ligated animal experiences a decrease into the overall tissue perfusion into the lower limb where we ligated the vessels, and this is measured in perfusion units with laser Doppler. And we did angiocps to be sure that those vessels, once occluded, remain like this, because rats are famous to develop collateralization. And here you can see the controls, and you can see the clips applied on the femoral, on the popliteal artery with absolutely no vessel about a month after radiation. And then we went on to generate the methylcoliforming cells, and we have used a protocol which was developed in our university by a colleague, Valentin Ordovi. This was actually an auto-transplantation experiment. So we took from live donors, we took the bone marrow from femurs, and bone marrow was purified on fibronectin to get rid of the rapidly maturing elements. And those which were actually the non-mature, the primordial cells, we incubated with a combination of cytokines and medium for 12 to 14 days after a protocol which has been already described. And these are the cells developing. This is actually day 4, this is day 7, and this is actually towards the end of the culture. They develop into a very specific cobblestone colony expressing all these kind of dendrites, and these are very specific for cells which we hoped to be neoangiogenic. Being neoangiogenic cells, they go into the vessel walls, and they are famous. The cells, especially from the media part and also from the intimate part of the vessel, are famous to take in lipids. This is the entire basis of the genesis process. So we took those cells and we gave them fluorescent marked lipids to see whether they can engulf this and they can eat this or not. And we were happy to see that those cells were very nicely accepting lipids. So we were a step further to see that those cells are really going to do some angiogenesis in vivo. And another thing which was also very important is that cells, once growing, they were forming neotubules. So this is the mother cell. You have to imagine like this is the mother cell and this is the dendrite developing. And then from these mother cells are other cells coming out and then they migrate on this dendrite and then further on. And this is how actually they expand to form the culture I've shown you. And another very important thing, especially specific for endothelial cells, was the vacuolization process, which we were able to see in macrogel cultures. Regarding the phenotype, they express a very specific phenotype for endothelial cells with CD34 still positive, with VEGF receptor 2, and very important CXCR4. This is a chemokine which is specifically excreted by ischemic tissues during disease, and is specifically excreted to harvest, to get neoangiogenic forming cells into that part of the body which needs actually new vessels. Very importantly, we have saw that during the culture, this is the first day of culture and this is the end of the culture, the percentage of CD34 expression was getting down, so those cells were actually maturing, considering the fact that CD34 is still a marker for naive, if you want to say, stem cell phenotype. And of course, having the cells, we tested them directly in vivo after the protocol, what I've just shown you. And this is the day 0 at injection, and this is day 15, and this is the day 30. And you can see a really significant difference into the perfusion rate of those hindlings. A perfusion rate difference which can be also observed into this graphic from day 0 to day 30 as compared to controls. Of course, we were happy to say that we had a ischemic hindling model which is very good, which can be further tested. We had some cells that were able to induce neoangiogenesis in vivo. Of course, lots of things still to be done regarding that concept before it could be a tool for clinical therapy. Nevertheless, we were very happy with the results, and these were published in the American Journal of Surgical Research in 2013, together with the group which worked very hard to obtain these results. I've been a researcher, but at the same time being a surgeon. I'm a plastic surgeon, and now in the second part, actually the third part of this presentation, I want to present you some things which I was able to develop and implement into the Department of Vascular Surgery and Vascular Surgery Hospital. And there were a number of domains in which I have worked, but due to the time limitations, I will only talk about upper limb, hand, and the lower extremity. And I will tell you very shortly about the orthoplastic approach, which was already present in the clinic. This is a concept which has been for years developed in Iraq. And then I'm going to talk about functional reconstruction together with peripheral nerve reconstruction. These two concepts went for us very good and go good together with patients having terrifying nerve problems which actually preclude them to have a normal life. And we, together with this concept of direct functional reconstruction, which of course was not invented by us, but it was for the first time implemented in our department. And last but not least, the field, the emerging field of perfect flares, which is nowadays still cutting-edge subject within our specialty. So regarding orthoplastic approach, I will only show you two cases. This is a case coming from the orthopedic department. This was an open 3D fracture, infected, and then we had to excise the tibial anterior tendon, and we also had to excise a good chunk of tibial diaphysis, leaving the patient with a huge defect here, and of course the patient is not able to ambulate. He had a huge complex tissue problem. So to resolve the tissue problem, we put him on an external fixator and we performed a free flap. This was a latissimus dorsi. This is the classical approach for this type of lesions. And then together with the international pluridisciplinary team involving our friends, Dr. Polizois and Dr. Grigano from Dr. Polizois from Athena, Dr. Grigano from in our university, we actually did what is called distraction osteogenesis. So the part of the tibia here was cut, and gradually this segment of the tibia was migrated down to land on this part of the bone. So after 4 months, you can see here, that's already the difference. And looking at 12 months, you can see here the newly formed bone and the landing side of the tibial fragment with the patient. This is the patient just before they took out the reserve distraction system, able already to ambulate. This is another case, a very young patient with an osteosarcoma in the forearm, which we operated together, again together with the group of Petru. And this is the tumor in the operation, and of course we had to resect a big part of the ulnar diaphysis, and we have put a substitute inside because the patient had to go to the oncological treatment. And after he came back from this, this is the image just after the first operation, and the ulna missing. When he came back from his oncological treatment, we have took out this material and replaced this with a free finger transplant, auto transplant, which went okay. The patient now said, well, this health can be already resumed. His new life, you can see here, the finger transplant. Peripheral nerve reconstruction has to do with microsurgery, but also has to do with functional restoration of the extremities in which you work. And in our clinic, we have successfully applied this type of concept, meaning that we perform in all of the patients I'm going to show you, we perform nerve reconstruction, peripheral nerve reconstruction, and we, in the same stage, we wanted to have very early functional reconstruction, not for the patients waiting for the limb to re-innervate, and we do this by 2 options, either functional muscle flaps or tendon transfers. And this leads to no need of prolonged splinting, earliest restoration of efficient grip, rapid functional recovery with very healthy patients. So I'm going to present a total of 18 patients which had different types of paralysis, either single nerve paralysis or combined, like median plus ulnar, median plus posterior interosseous nerve, radial, axillary, or common peroneal nerve in the lower extremity. All were traumatic lesions. There were patients coming to the vascular surgery department having major vascular injuries, which after revascularization remained with their concomitant nerve lesions and needed the attention of the plastic surgery team. Reconstruction was made on average about 6 weeks after the initial insult. In one patient with an axillary nerve paralysis, actually the functional reconstruction was performed in 6 years because it was all too late to achieve a very good reconstruction due to the absence of the nerve synapses of all these years. We have used in almost all patients the autorobusural conduits, and in one patient we have used the muscle veins conduit. Patients we evaluated with the MRC scale, which is, we used the modified one, and the lower extremity functional scale. This is the MRC scale modified. So I'm going to show you the first case. This is a 16-year-old patient involved in a car, he was involved in a car accident, common peroneal nerve avulsion with a lesion of the tibial artery. They have made hemostasis in a local regional hospital, but after the hemostasis, the wound healed very nicely. The patient was left with very bad paralysis of the common peroneal nerve. You can see here in the left leg that he cannot achieve dorsiflexion at all, meaning that all the nerves, all the muscles from the anterior lateral compartments of the shank are paralyzed. And this is the lesion we found intraoperatively. This is the profound peroneal motor nerve, and this is the superficial sensitive nerve, and this is the common peroneal trunk, and this is the scar, which was extensive, and then we performed reconstruction. And then during the same time, we performed a technique of tendon transfer, which was actually, this is not new, but was very much improved by Adolfo Vigazio. Vigazio is coming from the famous school of orthopedic surgery of Professor Brunello Brescia, And he described the technique where actually what you do is you take the tibial anterior tendon, you take it out from the retinaculum, and then by putting the journal in between the cuboids, you reroute this tendon. So actually, instead of being lateral the insertion will be medial. So when you re-engage this part of the tendon with the functioning muscle, then the patient actually will be able to achieve pretty good and much more stable dorsiflexion. So this is the technique, this is the rerouting, this is the tibial arterial already rerouting, this is how it's taken out on a dorsal aspect of the foot. Here you can see the patient about 2.5 months post-operatively, still not having the perfect dorsiflexion, but the position of the foot very much corrected and very heavy. Going to the upper limb, this is a classical distal type of radial palsy. This is a patient which has been bitten by a dog. You can see here the bites. And unfortunately, the dog bit exactly on the side when the posterior interosseous nerve gives its final branches. And of course, we have did the classical, we have did the exploration of the posterior interosseous nerve. We have did a neurolysis, and we have did classical tendon transfer,